you for joining us for today's International Myeloma Workshop Daily Update. I'm Mary DeRome, Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. I'm here in Vienna for the next few days, attending one of the premier meetings specific to myeloma, the International Myeloma Workshop. This meeting is held every other year and brings together renowned myeloma specialists from all over the world who present and discuss the latest advances in myeloma clinical research. I'm fortunate to be able to bring you updates from this important meeting every day that it's taking place. And just to ensure everyone that we are being COVID safe at this meeting, in order to enter the country of Austria, everyone has to be fully vaccinated. And at the convention center, we are tested for COVID-19 every day before we are allowed to go into the meeting. Today, I'm joined by Dr. Melissa Alsina from the Moffitt Cancer Center in Tampa, Florida, and Dr. Shaji Kumar from the Mayo Clinic in Rochester, Minnesota. Shaji, you were part of a plenary session yesterday on myeloma diagnosis and workup. Can you tell us if there's anything new regarding diagnostic tests for patients?
Yeah, so the diagnostic criteria itself has changed a bit over the past few years. One of the major changes that happened in 2016 with the revision of the diagnostic criteria were to group some of those patients with the high-risk smoldering multiple myeloma to the active myeloma category. Now, even though the change itself seems to be quite small and may affect only about 1 in 10 patients, it was a major shift in the way we think about the disease. Until that time, we would never treat someone who doesn't have what we call end organ damage, high calcium or kidney issues or bone disease. And with the revision to the diagnostic criteria, what happened was there were some patients with high levels of bone marrow plasma cells, 60% or more, or patients with a high free light chain ratio, or on an MRI of the spine, you're seeing abnormalities. Those patients are now being categorized as having active myeloma. So essentially now we are treating patients who are totally asymptomatic because we know that these changes are likely to lead to them developing those changes within the next couple of years. So act before something bad happens. So that, I think, marked a major paradigm shift in how we overall think about the disease and, of course, how we manage to diagnose myeloma. Now, in terms of the tests that we do, the fundamental principles haven't changed. We still need to demonstrate that these patients have a monoclonal protein or an M spike or M protein that are secreted by the myeloma cells. And we also need to demonstrate there are what we call the clonal plasma cells or myeloma cells, either in the bone marrow or the bloodstream or in a plasmacytoma. But the way we can demonstrate the presence of this protein or identify these cells have changed. So now we have a more sensitive way to detect this monoclonal protein or the M protein, which is called the mass spectrometry. So the mass spectrometry is much more sensitive. It's almost what we can call almost 10 times more sensitive than the test that we used to do, like the serum protein electrophoresis with immunofixation. So as a result, for patients with monoclonal gammopathy, you are going to identify more patients with a monoclonal gammopathy because the test is sensitive. But I think the more important thing is in patients with myeloma who are getting treatment, the ability to detect very small amounts of M protein that's still left behind after treatment can make a significant difference, especially in the future to identify patients with minimal residual disease. And we also have more sensitive techniques to look for these plasma cells or myeloma cells, both in the bone marrow and in the peripheral blood. Especially the flow cytometry-based approaches, we can detect circulating plasma cells in patients with myeloma more often. And there are multiple presentations during the workshop which have again shown that if you have circulating plasma cells, that does portray a poorer outcome for patients with multiple myeloma. There's some changes in the diagnostic criteria, which is obviously now a little bit older, few years. But in terms of these new tests that are being developed, they are clearly rapidly evolving. And it'll help us not only make the correct diagnosis, but more importantly, help monitor the disease over time.
Right. So, and the mass spec test is a fairly new test, and it's probably not that widely available to patients yet.
That is correct. I think hopefully it should be more widely available in the next few years to come. Right now, for example, at Mayo Clinic, we have routinely shifted to everyone getting the mass spec based testing. And that's partly because not only is it more sensitive, it's much more efficient in the lab, requires less people, less time to get the tests back.
Great. Well, that sounds like that the process of diagnosis will become faster and more efficient and also more accurate for patients moving forward, right? So that's always good news. Melissa, the first oral abstract session today focused on the treatment of patients with newly diagnosed disease. So there were a few presentations on the use of certain regimens for patients who are considered ineligible for autologous stem cell transplantation. So many patients in our audience know that a transplant is a part of the standard of care for most myeloma patients, but not everyone is a candidate for transplant. Can you first explain a little bit about how patients and their doctors determine their eligibility for a transplant?
Sure. So a transplant is a process where patients are given high doses of chemotherapy. So they need to have healthy organs to be able to tolerate this treatment. And that is more dependent on what is the patient's underlying health as opposed to age, right? So we don't make a decision based on age or chronological age. We make the decision based on physiological age and comorbidities. So for example, if a patient, I could have a patient that is in their 70s, but is a completely healthy individual with a normal heart function, normal lung function, that patient could be a perfect transplant candidate. Whereas I could have a 50-year-old that has congestive heart disease, right, and could not undergo that procedure. So it's based more on that, with the exception of kidneys, right? The patients with myeloma, as we all know, I mean, about 25% of those patients will have kidney insufficiency. A good number of those patients are even on dialysis, and we have learned over the years that that is not a contraindication for transplant. So we could do a transplant in a myeloma patient on dialysis or with renal insufficiency.
Yeah, there actually have been a couple of presentations that I've seen at IMW already about the concept of frailty and what that means to patients with their disease outcomes, and I imagine that also plays into whether or not they're eligible for transplant.
Yeah, definitely. Those are being used more and more in studying treatments, in patients in older patients with myeloma, and also they're more objective guide, right, to make these decisions. And again, it's more dependent on the patient's what we call performance status, which is how do you do in your day-to-day life? How active you are. What are the activities that you do? Can you take care of yourself or not? And so these are the things that are taken into account to make those decisions.
So we talked about eligibility for transplant, but so a couple of the presentations today really talk specifically about patients who are ineligible for transplant and what their treatment paradigm is currently and is moving toward. And we heard about the Mayo study and another study, a number of studies where basically Darzalex was being added to a triplet regimen to really help these transplant ineligible patients. So can you talk a little bit about that? And we also saw another presentation about Sarclisa, which is the other CD38 antibody used in combination for transplant ineligible patients as well. So could you tell us a little bit about those new results in Mayo and some of these other studies with these anti-CD38 antibodies and what that might mean for patients?
Right. So I think historically, we had seen the older patients with myeloma, what we would consider non-transplant eligible, as more frail patients, and we were shying out of giving the patients very aggressive therapy, right? So frequently we would do like a doublet, let's say lenalidomide and dexamethasone, and there have been studies done before, like the first study that had shown that if you treat these patients with Lendex and continuous therapy, those patients do quite well. I think what has really revolutionized this concept is the fact that now we have these monoclonal antibodies, like daratumumab and isatuximab, which target a particular protein expressed in the myeloma cells that is called CD38. And we have learned, I think, two important things from this. First, that these treatments, adding these treatments to, for example, Revlimid and dexamethasone, or even Revlimid, Velcade, and dexamethasone, is safe, is very well tolerated, and doesn't really add a lot of toxicity to the underlying regimen. But I think most importantly, especially for these patients with newly diagnosed myeloma, is that adding that agent makes a treatment so much more effective. There are multiple randomized trials, right, looking at what would be standard of care in the past for a non-transplant eligible patient, for example, like Velcade, melphalan, and prednisone, which is not a regimen that we use in the United States, but it's a very standard of care regimen in Europe. You add, a study done comparing that regimen versus that regimen plus Darzalex or daratumumab, and definitely much better progression-free survival, meaning, if the patient is treated with that regimen, the disease is going to stay under control longer. I mean, all these regimens already induce very high response rates. So those response rates sometimes are hard to beat, right? But I think what is more important is that it definitely deepens the response. So we're always telling our patients this concept about, we not only want the disease to get better and for the patient to get a good response, but we want to try to get the disease in complete remission. And further than that, minimal residual disease negative. And we've learned that if a patient gets that deep response, those patients are going to live longer and are going to stay longer with the disease under control. So when we are treating these newly diagnosed patients, we really want to make that our goal of therapy. And definitely these monoclonal antibodies, cetuximab, daratumumab, have definitely helped us get there. Not in 100% of the patients, but in a very high number that, we've never seen those type of responses before. For example, we've never seen before that we can give induction therapy to a patient and get 50% of those patients in complete remission, right, without transplant. And we've also learned that as we keep treating these patients, we have more opportunity to deepen the response as time goes by. So I think that's the message, is that these agents, cetuximab, daratumumab, should be standard of care, in the treatment of newly diagnosed patients with myeloma, and we're going to shy away from doing these doublets and going to these triplet combinations, sometimes even quadruplet combinations. And again, they add little toxicity, so majority of the patients can really tolerate these regimens.
So I think it's very reassuring to patients who aren't eligible for a transplant that there really are very effective therapies available to them. Even though transplant is standard of care, they can still get really good responses with some of these newer quadruplet therapies with the anti-CD38 antibodies.
I think in some centers, like in our center, and I would love Shaji to comment on that, we are sort of changing our treatment paradigm based on these results. For example, if I see a 70-year-old patient or older, I would treat that patient with more than likely lenalidomide, dexamethasone, and daratumumab. And if that patient achieves a complete remission, MRD negative, I will not take that patient to transplant, because I feel I already got there. I will save the patient that toxicity, and I think we're moving more towards that response-adapted approach to therapy, especially in that population.
Agree, especially because now there's more data coming out about the effect of melphalan, which is the agent in stem cell transplant, on the mutational burden of patients. That's a discussion for another day, but I think that sort of adds to the evidence there. So another thing that was talked about today in some detail was maintenance therapy. So maintenance therapy is another part of the treatment plan for newly diagnosed patients, and currently Revlimid is the only approved agent for maintenance therapy, specifically following a transplant. Many of our patient viewers ask if there's any other options for maintenance therapy, because Revlimid sometimes is not well tolerated by patients, and they have to go off therapy or decrease the dosage because the side effects are really too strong. So Shaji, can you talk to us a little bit about some of the data that we saw today with Kyprolis as a maintenance therapy? So we saw a number of interesting results from trials like Cardamom or the Forte trial, where Kyprolis was used in newly diagnosed transplant eligible patients, or even in high-risk patients as well.
Yeah, I think the concept of maintenance has become just a normal practice in myeloma, both in the transplant setting as well as in the non-transplant setting. And sometimes it's you can call it maintenance, sometimes you can call it continuous therapy until the disease relapses. Either way, I think sustained therapy for long periods of time has become the current approach overall for multiple myeloma. And I think, as you already mentioned, lenalidomide has become the cornerstone, whether it be in the post-transplant setting, in the lenalidomide maintenance, or the lenalidomide continued therapy, as in the first trial where they treated patients with Lendex until progression, or in the Maya trial that we just heard about, where the patients continued on daratumumab len until disease progression. So the question is, what else can we use? I mean, because not every patient can tolerate lenalidomide for that long. And also what we have seen in the post-transplant setting with lenalidomide maintenance, there are certain groups of people who don't benefit as much from the lenalidomide, which are the high-risk patients. And I think that's exactly where I think the other major class of drugs, which is the proteasome inhibitors, come in. And we don't have a lot of prospective randomized trial data with bortezomib, though we often use bortezomib in combination with lenalidomide as maintenance in patients with high-risk myeloma. We do have phase 3 trial data looking at ixazomib, which is the oral proteasome inhibitor, showing that there is some modest improvement in the progression-free survival or continue to control the disease for longer periods of time by giving ixazomib maintenance post-transplant. So I think the Forte trial actually just drives home the point, or the data that we have seen from some of the retrospective studies suggesting that using two drugs, a proteasome inhibitor and anti-immunomodulatory drug like lenalidomide together, might be the way to go for, especially for the high-risk patients. Now, the Forte trial looked at patients getting either carfilzomib lenalidomide or lenalidomide maintenance, and they were able to show that there was an improvement with carfilzomib lenalidomide in terms of how long the myeloma can be controlled. And I think the most interesting aspect was that you saw a very similar degree of benefit compared to just using lenalidomide alone for both the standard risk patients, the high risk patients, and what they called a double hit patients, which means they have at least two high risk markers instead of just one. Mm-hmm. And I think that data is quite intriguing, and certainly is consistent with what has previously been published. So I think based on the cumulative evidence, I think it's one main message I think from these presentations is that if you have high risk myeloma post-transplant, you should consider a combination of a proteasome inhibitor and lenalidomide. Whether that be bortezomib or carfilzomib, I think we have data for supporting both, so both could be considered. The second main message I think is the Cardamom study is the fact that you can use carfilzomib as a maintenance therapy as alone, and these patients can stay on it with acceptable side effects which can be well managed. I think it's important. Obviously, with the Cardamom study, it's a little bit more harder to tease out, the comparison of carfilzomib. But it's, again, they looked at patients who are getting the injection therapy, transplant or no transplant, and then going on to maintenance. But at the end of the day, I think it expands the options that we have in terms of what we can use for maintenance treatments. And I think the final point is, there was some data presented from Cassiopeia as part of the other sessions, where they looked at daratumumab as a maintenance therapy and showed that there is also benefit from using daratumumab as maintenance compared to no maintenance, though the benefit appeared to be mostly for patients who had not gotten the daratumumab as part of their initial therapy. But certainly now we have all the major three classes of drugs, all of them can potentially be used for maintenance depending on the given clinical situation.
Well, that's good news too. And we get a lot of questions from patients all the time about maintenance therapy and why do I have to be on it? How long do I have to be on it? And it's just so encouraging to see all of these trials ongoing and more therapies being tried. So I think that eventually we're going to hit on the right combination, that people will be very well tolerated and will be very effective at the same time.
And not only just the right combination, but also the right duration, which I think the second question still remains unanswered, how long it has to be.
Yeah, there you go. So speaking about duration of maintenance, Melissa, another topic that people always ask about is minimal residual disease, which people talk about a lot as far as determining how long maintenance should last. So people want to know about MRD, how is it tested and how often it should be tested. And what can you tell us about MRD testing based on what we've learned at this meeting so far this year? And I'd love to hear you both comment on whether there's evidence to suggest that MRD test results can help patients and their doctors make treatment decisions based on that data. Melissa, you can go first.
Yes, so a very exciting and important concept. So for those patients that might not be familiar with what MRD is, right? So it means minimal residual disease. And what that means is that when you're in remission, we look at the bone marrow, we don't see any myeloma cells, we look at the blood work, we don't see any abnormal protein in the blood or in the urine, and we say that patient is in remission. But we know that patient is not cured, and we know there's some myeloma left over, right? And so we have some special tests that we can do, sometimes in the bone marrow, sometimes in the peripheral blood, or both, that could help us identify disease that we cannot see with our eyes, right? And they are, nowadays, we're doing that more commonly because there's a particular test that is called clonoSEQ that would help us identify a particular mutation that each patient would have when they're initially diagnosed, and that mutation is in the myeloma cell. So we can identify that mutation when the patient is diagnosed, and then when the patient is in remission, look for that mutation. And those tests can help us identify one cancer cell in a million cells in the best scenario, right? It could be a little bit less than that. But what is important about this is that there, over the years, and this is not precise, this is not new from this meeting, right? But over the years, we have learned that if a patient can get to minimal residual disease negative, meaning I cannot identify any residual myeloma, those patients live longer, stay longer with the disease under control. So there are many trials that are looking at how to use this to adapt therapy. So I was talking before about response-adapted therapy. Now it's like minimal residual disease-adapted therapy, right? So I think it's clear that that is important and that we should try to get the patients to that level, right? Now, not all the patients, can get minimal residual disease negative. And I think what we're trying to learn now is, do we need to push for that, right? Do we need to adjust our therapy based on that? And one thing, important concept that came across today in multiple cases, that it's not only about getting to that MRD negative state, but sustaining that MRD negative state, right? So as a doctor, for example, if you're getting a maintenance and we do that test and you're negative, I probably will not stop the maintenance based on that, right? Because I want to know that actually persists. And there are several trials that show today that, for example, MRD negativity at 1 year post-transplant or MRD negativity at 9 months is what really correlates better with, better time with the disease under control and better survival. So maybe what I'm going to say is not going to be very popular with patients, but as a myeloma doctor, I would really want to try to keep my patient on maintenance, as long as I can, to see if we can get to that state. And I think outside of a clinical trial, it's hard to make these adjustments because we don't have that information yet. And I think it's easier, for example, for me, let's say I have a patient that I'm treating, the patient is minimal residual disease negative. I repeat again the test in a year and now it's positive. I know better what to do with that information than what to do with is negative. I will still feel hesitant of taking the patient off therapy, even when the patient is MRD negative. But if the patient is positive, I definitely would want to keep that patient on therapy or even adjust my therapy to see if we can change that.
Yeah, no, I think it's one of the most important areas for myeloma right now. There are obviously, we already talked about clonoSEQ, and there's clearly other approaches like the flow cytometry-based approaches to do the MRD testing, and as we talked about, the mass spec might be another way to complement the ability to
these are all tests that aren't widely available in the community. They're certainly available quite widely in major academic centers like where you guys work, but it's not so widely available in the community.
Yeah, it isn't, but I think part of the reason is because we don't know what to do with the test result in the majority of the settings.
Right. There really are no set guidelines right now.
Correct. I mean, it's a good, what we call a prognostic tool. So you take 100 people, 50 patients who are MRD negative at a comparable phase in their treatment are going to do better than the ones who didn't get there. Now, will changing the therapy, if you give them extra treatment to that 50 people to get them to be MRD negative, will it change their long-term outcome? We don't know the information related to that. Now, so the question is, one, can we act upon the information? And two, if we need to act upon the information, who are the people who are going to benefit from acting on that information? I think the best data is for patients with high-risk myeloma. I think we all feel very comfortable saying that if you have high-risk myeloma, it's more important for us to be able to get you to be MRD negative. So we are willing to go an extra step to maybe change therapy or add more therapy to try and get them to be MRD negative. We are not entirely sure if we need to do that for everyone, especially with the patients with standard risk disease. We know from past experience, even when they don't get to a complete response, they could do sometimes well. Myeloma could stay under control for years. So we don't want to over-treat and give the toxicity that goes along with it. So I think there's a lot that needs to be learned in terms of what do we do with the test result. And the trials are looking at if it's positive at a given phase in the treatment, do we intensify the treatment? Or if it's negative, do we stop treatment like we talked about in terms of maintenance therapy? So until those results come back, I think maybe the high-risk patients are one places where we would feel comfortable using that test. Now, having said that, are there other situations where it might be useful? So let's say somebody with standard risk myeloma has a lot of side effects with the maintenance treatment, and they are kind of sitting on the fence. Do I really keep pushing this or do I go off it? In those situations, if somebody is MRD negative, and especially as Melissa said, if they're been MRD negative for a year now, maybe we can push the fence, push them off the fence in one direction versus the other. So I think it all has to be kind of in a nuanced fashion in the clinical context.
And right now, MRD is most sensitively measured from a bone marrow aspirate, right? And this whole process would be so much easier if we could just do it from the blood, right? So is there going to be a time where we'll be able to very sensitively measure MRD just from a blood sample of a patient? And how far away do you think that is?
I think we have still ways to go to get to a test that is more sensitive than what we can do in the bone marrow. So again, as we said in the beginning, there are two ways to look at the myeloma left behind, right? Either you see the cells or the DNA, or you actually see the protein. The protein with the mass spec, we know that we can get to be very sensitive. And there are additional mass spec methods which are more laborious, which can even go down to a more sensitive level. So that's one option. The second is to look for the DNA or the cells in the bloodstream. And there was a really nice presentations from yesterday which talked about how we can measure the circulating tumor cells, circulating tumor DNA. Right now, they seem to be at least a 10-fold less sensitive than what we see in the bone marrow. But I think as the technology evolves, I suspect we are going to be able to detect that with a greater sensitivity. And at the end of the day, it may not be just one test. It could be looking for the cells, the DNA, and the protein together.
And just make sure everything correlates, right? So, I mean, if single-cell genomic sequencing can be done on your myeloma, then this testing MRD in the blood can't be far away.
Yes, technology is certainly fast evolving. For sure.
It's very fast evolving. So, Melissa, today we did see a presentation by Dr. Sagar-O'Neill on iberdomide, right, which is something that many patients are interested in learning about. So it's been mentioned as a new generation of the same class of drugs as Pomalyst and Revlimid. So can you tell us more about this drug in this new class and whether patients need to discuss it with their doctors? From what I saw today, it looked like it had some pretty reasonable activity in combination with a number of more common drugs. And it seemed to be quite well tolerated.
Yeah, I think it's pretty exciting data. So this drug is the same family of the Revlimid and the Pomalyst, so it's an immunomodulatory drug. However, it seems to be more potent, maybe because it looks like the drug binds more tightly to the target in the myeloma cell than the Revlimid and the Pomalyst. And also because this drug actually kills the myeloma cell as opposed to just keeping the myeloma cells from growing, from proliferating. So that might be the reasons why it could be more active. And then Dr. O'Neill presented the data on a study where they did with multiple cohorts using this drug for patients with relapsed myeloma in combination with Darzalex, daratumumab, another cohort in combination with Velcade, and another cohort in combination with Kyprolis. And they show very good activity. Given that this patient population was patients that have had myeloma for a while, have failed 6 prior lines of therapy, right? And also, actually, the majority of these patients had disease that was refractory to immunomodulatory drugs, to lenalidomide and pomalidomide, and also refractory to proteasome inhibitors like Velcade and Kyprolis. And they saw responses about 50% or so. I think the responses were slightly better with the Velcade than with the Darzalex, and then with the Kyprolis, it was a very small cohort of patients. But anyway, very exciting data, because this is not, when we treat a patient with relapsed myeloma that the disease have been resistant to those kind of therapies, we usually see responses, in the 20-30% range, right? So this is a little bit better, and the medication is also very well tolerated. I mean, we see more or less what we see with the other immunomodulatory drugs, like low blood counts, but not severely low, some fatigue, some rashes, but it's exciting, and I think learning more about using this drug earlier on in the course of the disease, and also in combination with other combinations, looks promising.
Yeah. So I mean, the data that was presented today was from a phase 1/2 study, right? And it was admittedly sort of a small number of patients. There weren't more than like 50 patients, and I think in the 3 groups that he had. But I guess the data that they saw was good enough, and now they're going to start phase 3 studies with this. So we'll be able to get a better answer for this pretty soon. So that's good. It's good news. You guys have been really patient, answering a lot of my questions. So this is my last question of the day. So Shaji, I'm going to start with you. So if a patient comes to you for their normal appointment in like the next week or 2 or whatever, and they're like, "So doc, I heard you were in Austria at the IMW. What did you learn that's like important for me to know as a patient?" What would you say?
I think the most important thing is hope, because there's so many new drugs that are coming through. I think we have already seen, I think as we already talked about, even in patients who are not getting transplant, we are talking about their first treatment, keeping the myeloma under control for 5 years. I mean, that we wouldn't have thought about it 10 years ago. And that is just what we know already. And we heard about a whole different immunotherapies, which are very exciting. The CAR T cells, we heard about the bispecific antibodies. All of them, just by one drug itself, can give responses of 60, 70, 80% in patients who have become, all the therapies have stopped working. I think that is a huge jump in terms of what we have been able to achieve in this field. And couple this with the ability to detect very low levels of disease. And I think all this point towards us being able to start curing an increasing fraction of patients with myeloma. And I think the other important thing is, not only do we have better therapies, we are also starting to explore these exciting treatments much earlier on, to trying to see maybe they never have to deal with myeloma at all.
Yeah, and that's really an exciting prospect. Melissa, what would you tell that patient?
I guess the same thing that Shaji. No, but I think it's really exciting and amazing to me. We've been treating myeloma patients for many years, and it's really incredible, right? That every time we come to these meetings, year after year, we can get out of the meeting with new things, with more excitement, with things that are being developed, and every time it really gets better, right? And this time, as Shaji mentioned, the biggest excitement is about these immunotherapies working in myeloma in ways that we haven't seen anything work in the past. To see a patient with relapsed myeloma that really had no other options get a CAR T and had a 80% chance of getting in remission. I mean, that's just unheard of, right? It's unbelievable. And so that's super exciting, and the ability to already start, learning, okay, I mean, we know these patients don't cure, these treatments don't cure the patients in that setting, right? But we're already learning how to improve on those, right? What can we do after CAR T so that the response is sustained? And if you think, if you see that a drug in myeloma in that setting can work at that level by itself, then imagine what we could get when we combine them, right? So no, it's really amazing, and I think, I agree. The best word is hope.
I thought Ken Anderson this morning, when he gave his plenary talk, early this morning about, some of the most recent advances in myeloma, put it very well, saying that the golden age of myeloma is still yet to come. And I think that that's probably about as hopeful as it gets.
The beauty, I think, of all this is that these are these are tools and treatments that, we did not have a year ago, and now we have them, right? And every year we get something new that we can offer our patients, and so it's in real time, right? It's not like, okay, this is going to come in 10 years. No, it's coming soon, and it's coming now.
Great. Okay, so I think I've asked you enough questions for today, so thank you for your patience. On behalf of the MMRF, I'd like to thank Dr. Alsina and Dr. Kumar for joining me today during this busy but exciting time at the International Myeloma Workshop. I'd also like to thank everyone watching this update, and finally, I'd like to thank our sponsors, Janssen, Karyopharm, GlaxoSmithKline, and Oncopeptides, for helping us put these videos out for you. So if you have any additional questions on what you've heard today in these discussions, please don't hesitate to call our MMRF Patient Navigation Center at 1-888-841-6673 and speak to our patient navigators who can help you with any questions you might have. Thank you, and I'll talk to you again tomorrow.